Hey, everybody. Welcome back to the You're Not Broken podcast. Today, it's going to be a fascinating conversation with Dr. Mark Horowitz, who literally wrote the book, Prescribing Guidelines, Antidepressants, Benzodiazepines, Gabapentinoids, and Z Drugs. Look at this textbook. I wrote two layperson books. How did you do this?
So it ruined my life for a few years. That's how I did it. So I'm glad that someone other than my mother has bought it. So it's nice to see it in your hands.
It's a very big deal because I think it's a conversation that I think is just starting. SSRIs and antidepressants and the drugs before them have been around for decades. And I think, I've been saying this for a couple of years on the podcast of you can't put 25% of American women on a drug and not have a reckoning coming. And I really do. There was just an article in the Wall Street Journal about this. I think the reckoning, if that's the right word or not, is coming of how did we get 1 in 4 American women on these medications? Is that the right thing to do? And can we get them off? So thank you so much for coming onto the podcast today.
My pleasure. And it's how do we get people off a drug that doesn't have an inbuilt off ramp? That doesn't, I sort of say it's a bit like putting cars on the road without brakes, because there really wasn't given thought after years on the drugs. How can you stop these drugs? After a few weeks, it's very easy. That's not a big deal. But now we have not just 1 in 4 women in America on these drugs, but a lot of them are on it for years or decades. So there are 25 million people in America who are on the drugs for years now.
Yeah. How did you get into this topic?
I'd like to say it's because I'm, very intellectual and academic.
Innately curious.
Yeah, I am, but no, unfortunately, it's because I sort of fell down a manhole in the street. The SSRI manhole. I guess briefly, I took antidepressants for many years, like 1 in 6 adults in the Western world, America, Europe, Australia. I did a PhD. I trained as a doctor. Started my training as a psychiatrist. I moved to London to do a PhD in how antidepressants work, the biology of depression. I thought I could stare down a microscope and work out what is going wrong in my mind and the mind of my family. I'll fix my life with microscopes, the delusion of the young nerdy man. And at the end of my PhD, I read an academic article that talked about withdrawal effects from antidepressants. And I found that very startling because I hadn't come across that in my medical training, in my psychiatry training. And my first thought was basically drugs that cause withdrawal are not very good for you. Benzodiazepines, opioids, everyone will know OxyContin in America, or street drugs, recreational drugs cause withdrawal effects. It means, 2 things to me. One, withdrawal effects means the drug wears off because tolerance and withdrawal are 2 sides of the same coin, and that drugs that cause withdrawal generally aren't very good for you. So I thought at that point, I've now been on this drug for more than 10 years. Is it still doing anything because of tolerance effects? Mm-hmm. And is it good for me? Mm-hmm. And I had a few health issues that I had had since I'd been on antidepressants, and they were being tired all the time. It had profoundly affected my life. Issues with concentration and memory, and once my memory had been, brilliant, and it was sort of going down the drain over the time that I was on these drugs, which was my 20s. So not normally when your memory goes down the drain. And I'd always had in the back of my mind, is it the drugs? When I read that article about withdrawal effects, that was the trigger for me to try to come off the drugs. And I, again, in nerdy fashion, I went and read every article that had been written about how to come off these drugs. And some of them were written by my professors because I was then doing my PhD at King's College in London that passed Harvard as the most cited research institute for psychiatry in the world. So I was working with, all the top people. And they all said coming off with antidepressants is very easy. Few weeks, halve the dose, halve it again, stop it. You might get some mild discontinuation symptoms, this kind of industry euphemism. I thought, all right, that sounds pretty good. And then because I'm a millennial, albeit a pretty geriatric millennial, I went and checked Google, and it gave me a very different story from people. They said coming off antidepressants was one of the hardest things they'd ever done. It took them years. They were forced to be sort of Walter White-like characters from Breaking Bad in their kitchen and grinding down tablets, mixing up liquids.
Really having to microdose.
Microdosing,
teeny decreases in these drugs. Otherwise, you get big withdrawal symptoms.
Exactly. Thousands of a milligram, kitchen chemistry, all of this stuff. And I thought, I sort of didn't know who to trust. I'm a kind of fairly institutionalized person with 6, academic degrees, used to listening to professors. These were sort of unknown people on the internet. So I sort of split the difference and I came off my antidepressant in a few months. Not the years these people talked about, not the kind of weeks that the professors talked about. I used equipment from my molecular biology lab. I used pipettes. I was a Walter White, not as much fun, didn't make as much money. And I thought I was being very careful. I was going a lot slower than, the guidelines said. And as I got to the end of my taper, coming off these drugs, my life exploded. I had trouble sleeping. I would wake up in the mornings in full-blown panic, terror, like I was being chased by a wild animal. I had sweaty palms, heart pacing, racing, and I would be in that state for 8, 9, 10 hours of the day. Panic I'd never experienced before. It was excruciating. I felt dizzy. Things around me appeared unreal. I had never had anything like this before. When I went on the drugs, I was a miserable young man, didn't like my course, didn't know who I was, standard existential things in my 20s. When I came off the drugs, it was a different level of intensity. I'd give it 3 out of 10 when I was 21, when I went on the drugs. When I came off in my 30s, it was 10 out of 10. And week after week of those symptoms went on, and I tried to white knuckle through. I took up, I ran 10 kilometers a day. I ran until my feet bled. I listened to hundreds of body scan meditations from John Kabat-Zinn, which I now know off by heart. He's got a very soothing voice. And after a few weeks, that I thought I cannot continue like this. It was just the most, terrifying experience every morning to wake up to that. And I eventually
went into this very intentional, like knowing you might have side effects, knowing it might be uncomfortable, but you had no idea.
I had no idea what was going on.
And it seemingly was not ending.
That's right. I mean, I thought I could do this for a couple of days, I could barely. But after 6 weeks or 8 weeks, I thought, I'm exhausted. I'm terrified. I was sort of like shaking like a leaf. And I thought, actually, I come across people as I was coming off who had exactly the same health effects as me. Lots of tiredness, lots of concentration problems, lots of memory problems, which it turns out has been shown in studies. We can come back to that. So I sort of thought, being on this drug has caused me serious health problems. Coming off it has almost killed me. What the hell do I do? And in the end, I sort of had no choice. I went back on the drugs and things did settle down for me, which actually is quite lucky. Some people, when they go back on, they can't quite put the toothpaste back in the tube, but it did for me. And I realize now I'm on these drugs, not because they're helpful, but because I'm trapped on them. I can't get off them because the withdrawal is too severe. And basically I went back to my training. I forgot about this for a couple of years because it was so frightening. And when I came to come off my drugs again a few years ago, I understood who the experts were now. They weren't my professors. There were people on these online forums who had been forced to become experts, retired engineers, homemakers, truck drivers, and I followed their guidance. I thought, this is kind of absurd. I've got 6 degrees in medicine, science, psychiatry, but I'm following guidelines from an online social media group. And I did come off my drugs with their advice. It took me years, not weeks. And I had to go down to very small doses, like you mentioned. And a lot of those health problems that I had on the drugs did clear up. Fatigue, memory, concentration. I went back to working full time. I had been impaired when I was on the drugs. I sort of thought this is kind of ridiculous. And I wrote an article about the things that I'd learned from coming off the drugs from these groups, combined with some neuroimaging from research that I'd been aware of during my PhD. And that article on how to come off antidepressants was published in the Lancet Psychiatry, a very good journal in Europe. And it has triggered changes in the guidelines in England over the last few years. They now more and more say what I say in that paper, and they give advice to doctors. And we're sort of working on ways of educating doctors. It's been very it's like turning around a super tanker because they've been sort of taught these drugs are very easy to stop. And there's been some progress. I run a clinic now, publicly funded in the NHS, the Public Health Service. But around the world, there's been very little attention, especially in America. In America, it's been very much a kind of hand over eyes, fingers in ears. These drugs are still fine, minimizing, denying. People don't have trouble coming off. It's in their heads. They must be very ill. They must need the drugs. And so,
withdrawal symptoms are a sign that you actually need the drug.
Exactly. So, if you feel bad when you come off your antidepressant, the most common response of a doctor is, if you feel bad and you're off your drug, well, you must need to be on your drug. That's the sort of knee-jerk
It's like
response.
telling an alcohol withdrawal, like, you need the alcohol.
Exactly. You
Ah.
need alcohol to prevent relapse of your anxiety or depression. That sounds ridiculous when you think about alcohol or cigarettes. But with antidepressants, because they've kind of been, they're a famous product, their doctors give them with white coats, it's all been kind of sanitized. And so withdrawal has been pushed under the rug, and they use euphemisms. They don't even talk about withdrawal in America. They talk about discontinuation symptoms, which sounds, very soft, very benign. My joke is it's like describing a car crash as a discontinuation event involving a wall. It sort of sounds a little bit softer than what's really happening, because I absolutely hit the wall, when I came off my drugs.
I have to think the amount of emails that you get from people. I mean, just the sheer number of people who are on these medications, and then for them to find that there's actually a person who's trying in a systematic way to help and not.
Yep.
Dismissal's huge in healthcare anyways, but this is a huge dismissal area. Like, your emails have to be every single day people emailing you.
Yeah, you've got it. I've had, I think last count, 15,000 emails from patients around the world since I've started working this area. I get several every day, mostly saying my doctors told me, I must need the drug. But I said to them, I went on the drug when my wife died 10 years ago. I was, low in mood, definitely. But now I'm having panic attacks. I can't sleep. I'm having brain zaps, as little zaps in my head.
Yep,
and he's telling me this is just a form of anxiety. And he sounds, quite mad to me. He won't help me come off the drug. He says that I need it. And if I stop it, it's against medical advice. So I've sort of been thrown out of my doctor's office.
They feel very trapped.
Well, yeah. So what do I do now? Exactly. Where do I go? And that's why they end up on social media sites where people are much more sensible, sort of ironic, a bit of an inversion of the usual order of things.
Right.
When it comes
Well,
to this
that's,
topic.
that's menopause and hormones too, just to tie it in.
Right.
Of like,
Right.
the real news is on the internet. I mean, there's a bunch of crap on the internet too, but like the real story, like you found, like the real story is in the people trying to figure out how to come off of this, because the medical system never kind of planned for this long term. I think in America, it's also complicated because we're one of the 2 countries in the world that can advertise pharmaceuticals directly to people. And these ads make it look as if all of your cares are gone.
Right. Yes. Happy people running in the sunshine with, yes.
Yeah, making dinner for people and, having great relationships. And there is kind of this like sheen on top of these medications that like you too can have no worries. So the question, and I think you touched on it, and I want to go deeper. The question is, if you've been on it for a while and it's really hard to come off, why stay on them? And I think what you were alluding to is because these medications in and of themselves have side effects because you're taking them. They have side effects. Can you go in? Because I think a lot of people don't know that, of like, well, why not just stay on them for life?
Sure. It's a great question. I mean, so one, the drugs have lots of side effects. And, why is that not central in people's minds? I think there's a couple of reasons. One, there's a kind of reassuring line given by doctors, which is these side effects will go away, they're just there for a few weeks. That's not accurate. In long-term studies of people on antidepressants, most have side effects, and many people have multiple side effects. I think one of the reasons people don't put it together with the drug is they're insidious. It takes time to build up. So, for example, if you take an antibiotic and you vomit your guts out the next day, or you have diarrhea, it's obvious it's the antibiotic. No one is confused about that. But if you take an antidepressant for 10 years, and every year it makes you 5% foggier later, your concentration off, you don't notice that. If you're in your 60s or 70s, people will say to you, well, you're getting older. It must be that. If you put on weight, they'll say you're getting older. If your sex drive goes away, they'll say you're getting older. So all of these things are a little bit harder to pull out than vomiting from an antibiotic. But studies show the following. Antidepressants cause significant weight gain. In the short-term studies, it didn't show that. Over 6 weeks wasn't enough time. But over years of use, 30% of people will go from being normal weight to being overweight, or going from overweight to being obese. So it's a significant, it's several kilograms.
They've compared that against placebo or people not on antidepressants. Is that how they've figured that out?
They've compared it against people that are not on antidepressants, that are age matched and matched for other characteristics, because there aren't long-term randomized placebo-controlled studies. That's part of why there's, a little bit of a lack of clarity about this, because the companies haven't looked at long-term effects. There are also...
Why would they want to?
Exactly. There's no incentives, drug companies.
That's expensive, and 25% of Americans are already on it. I don't know if it's higher. Is it higher in any other country? Like, not to compare, but like it's very high in America.
I think that, in a lot of things, this is where America is number one. You guys are behind
We're
in a few things, but in this, you're number one,
We're
definitely.
4% of the world's population, and we take something like 70% of the pharmaceuticals, 70 or 80% of the pharmaceuticals, like 90% of the opioids. We are winning in a very losing sort of way.
Definitely. Yes, first and coming last.
Okay, and one of the things that I was discovering, and I was discovering this because I was getting into hormones and menopause and the risks of hormones, etc. And I got down the rabbit hole of SSRIs and the independent risk of bone fracture with
Yes.
SSRIs, to the point that there's multiple meta-analyses on this. Like, it's actually well studied, well published. Then I talked to an orthopedic surgeon friend. And I said, do you know this association? And he's like, nope. And I talked to a primary care friend. And I said, do you know this association between SSRIs and bone fracture? Nope.
Right.
They think it has to do with the serotonin effect because bones have serotonin receptors in them. But I'm like, you're putting these on people who are older, getting frail, gaining weight. These are high-risk fall people, and they're taking a medication that they don't know is independently associated with bone fracture.
Yeah. I mean, so just I'll go to that point now. I mean, so serotonin and other chemicals that these antidepressants affect, people think that they're just in the brain, they're just to do with anxiety. But of course, they're pleiotropic hormones. That means they have multiple different roles in different parts of the body. They affect the way that smooth muscle works in the bladder. They affect the way that platelets aggregate to form clots. They affect, the autonomic nervous system, so they affect blood pressure and dizziness. So in older people, yes, osteoporosis is increased with use of antidepressants, so your bones are thinner. You're also more likely to have a fall. People think because you're dizzy, you've got postural hypotension, and that is probably what contributes to the overall effect of having more fractures. You're also more likely to have various different cardiovascular events like stroke and like myocardial infarction. And people think maybe that's to do with the platelets, because platelets are not clotting as well as usual because you've got serotonin playing a role. Now you've got too much of it. It's inhibiting platelets, so you're more prone to bleeding risks. There's also signals that there's an increased risk of dementia with certain antidepressants, particularly cholinergic ones like Paxil or paroxetine. All of these things are associations because there aren't randomized controlled trials of placebo versus antidepressants. So what these studies involve is they compare people that are on antidepressants and not on them, and they try to control for them. So you can't make a perfect causative argument. But the other argument is that people that are depressed have this happen more often, but it doesn't make any sense. Why would a depressed person have more osteoporosis? These people, most people are not they're not so depressed they're lying in bed for 20 years.
Right.
So, there's not a plausible explanation. And so it's
I've seen the
very
explanation.
likely.
Yeah.
Yes.
I mean, I've seen depression is an independent risk factor for dementia. But if you're on the SSRI or antidepressant, the theory should be you're not depressed. So maybe you should have lower risk of dementia.
Exactly. And that's not what it shows. Exactly.
And it's not what it shows.
So the studies don't show that. Depression may not be good for you. I'm not arguing that it's good for you, but these studies are showing that antidepressants themselves are associated with all these negative outcomes. Those are kind of the long-term health thing. I should add to it. The other thing they find in these studies is that you die earlier. So that people on antidepressants have greater mortality than people that are not on antidepressants. And it's quite significant for some antidepressants. So the average...
Are we talking years?
We're talking about percentage dying per year, and so it does turn out to be years. So for example, someone who's not on antidepressants over the age of 65, their chance of dying per year is 7% every year. And on certain antidepressants, the risk goes up to 11%. So there's a 4% increased risk of dying. So over a number of years, that does add up. And so the answer is yes, it does seem to be associated with an earlier mortality by several years. Whether it's causative or not, it's a question mark, but it doesn't look very encouraging. And some of these things have dose-response relationships. The higher the dose you're on, the greater the risk of these outcomes. That's the sort of long-term health consequences. The other side of things are the kind of known side effects. I've talked about weight gain. There's also sexual problems. So we know that the rate of treatment emergent sexual problems, this means before treatment, no problems, after treatment, problems, is between 50 and 80% for different antidepressants. That means reduced desire, reduced ability to be aroused, to sustain an erection as a man, or to have an orgasm as both sexes. So it's the majority of people. And we also know that for some people, when they stop antidepressants, these issues persevere. And they call this post-SSRI sexual dysfunction, PSSD, another acronym. And there's a debate about how common it is. And there's a study that suggests it may be as common as 1 in 7 people on antidepressants, which is really terrifying because most people have been told, okay, you might have sexual problems on the drugs, but if you stop them, they'll go away. And some of these studies are showing, that's not the case. And there are some very unhappy people, young people and older people, who are off antidepressants and still have these persistent issues after being on them. So I think that's a
And
good
I bet they
reason.
get dismissed like nobody's business because doctors aren't good at talking about sexual health anyways.
Yeah, yeah.
And the kind of the stigma of the protection of SSRIs culturally in medicine, where I see this in America, and I don't know if this is the same where you are, but when people even bring up the idea of, is an antidepressant the right thing to do? Are there options besides antidepressants? It's always marked with, but for people who really need it, you need to keep taking it. Like there's always this like
Yes.
statement after it,
Yes.
which we
Yes.
don't say with high blood pressure medication or any
Right,
other
right.
medication. There's like this protection
Yes.
of these medications. Do you see that also?
Yes, that is. I think that's just to do with 4 decades of relentless marketing. It's sort of, if you think back to opioids, antidepressants are not as dangerous as opioids because opioids make you stop breathing. So they've got clearly a much higher mortality. But there's something similar in the structure of marketing. What we talk about opioids, doctors, you should look for pain. It's the 5th vital sign. You must treat it. It's very unethical not to treat it. These drugs are not addictive. They're very helpful. All those things are basically not true. They're not very effective in the long term. Chronic pain, lots of pain goes away by itself. They were addictive, et cetera, et cetera. And I think with antidepressants, there's been the same kind of bombardment of propaganda. The antidepressants are very effective. Studies show it's very difficult to distinguish placebo from antidepressants. The effectiveness is very minor.
Yep.
Antidepressants are life-saving. It's another line that's not borne out in research papers. If you look at randomized controlled trials in young people, there's a clear effect that antidepressants make people more suicidal than placebo does, which is why there's a black box warning from the FDA on antidepressant packets. In adults, the debate is there no effect of antidepressants, or do they also slightly increase the risk of suicidality? So there's no studies that show that antidepressants reduce the suicide rate, but they've been talked about as life-saving, as part of kind of a marketing push. And that's where all this, you must use them because otherwise, you're not doing right by your patients and you must own your drugs. I think that's been kind of talking points that have been pushed out over years, and become almost self-perpetuating.
I see the other thing in America because we have the fear of litigation, and you're much more likely to get sued for not prescribing the antidepressant and then something bad happens to that person.
Yes.
Then
yes.
I prescribed an antidepressant, something bad happened to that person. Yeah, at least you tried.
Yes. Yes.
Like, and it's that like first do no harm, which gets very mixed up in the try
Yes.
not to get sued, which
yes.
is
yes.
very real in America. It's very
Yes.
real. People stop being
Yes.
doctors over this.
Yeah. So, I mean, you're right. It's, they say the sins of omission are punished more than sins of commission where you do something. It does come, there's a few kind of famous lawsuits where people have sued for not being prescribed antidepressants, but the opposite hasn't happened. I think you're right. I think legal risk is a very central part of doctors' thinking. They want to get home, pay their mortgages, they don't lose their jobs. It's unfortunate because, antidepressants do not reduce the suicide rate. They probably contribute to it in many ways. Lots of people recover naturally without medications. There are lots of effective treatments that don't involve medication for depression, but, no one's ever sued, as you say, for prescribing one. Whereas I think they should be, because some people get trapped on them. People get really unwell coming off them. They're disabled. But you're right, the kind of legal pressure is in one direction to prescribe. And so doctors feel much more comfortable prescribing than not prescribing. And I think that's, that kind of distorts medicine because this is sort of a fear based on litigation, not on the best practice for patients.
Absolutely. I see a lot of people come in to my clinic, usually for hormone issues and sexual health issues, and they're on an SSRI. And I say, why are you on this? And they don't know why they've been on it. Like they can't tell me why I'm on this. And they can't tell me how long they've been on it for decades at this point. It's just kind of like part of what, and we're working kind of against it, but to tell somebody like, hey, this thing you've been taking for 2 decades might be contributing to your anorgasmia, your low desire, your inability to lose weight, your X, Y, and Z. It's not crossing their mind because
Exactly.
it's just so normalized.
Yes, and and this is the other thing with a long-term drug, you almost can't remember how you were before you were on it. If you started at
Certainly.
20 and now you're 40 and you're having worse sex life, you can't quite be sure. I'll just say that's a very classic situation. This is the most common story. Someone has something go wrong in their lives. They get divorced, they lose their job, they fail an exam, their mother dies, they're miserable, they get put on a drug, and no one reviews it. Now, I think, just take a step back, we are medicalizing lots of normal misery. Everybody's mother dies. Everyone will lose a job. All relationships, have problems. The natural history of these conditions, anxiety and depression, is very good. Even very severe depression, 85% of cases resolve without treatment within a year. And by 3 months, about half of people feel better if you do nothing. So medicine has really pushed forward. This is an illness. We need to treat it. So it's already a lot of medicalizing. Even if you accept that, most guidelines in America say for an episode of depression or anxiety, you should be on an antidepressant for 6 to 12 months. But most people don't get their drugs stopped because doctors have priorities elsewhere. They don't know how to do it. They've had bad experiences. They back away from it. And so this is how a single event in someone's lives in their 20s or 30s or 40s can lead to decades of treatment, because doctors are much better at starting these drugs than they are at stopping the drugs. And that's how this sort of, a bad episode in someone's life can lead to lifelong treatment with these drugs that can have quietly toxic effects, on sexuality, weight, concentration, memory, sleep, you name it.
I didn't know stroke risk went up. That's new to me.
Yeah. It fits with the bleeding. It fits with all the issues with clotting, probably. That you've now got issues with, bleeding risk. What are the things that to do with bleeding are cerebrovascular issues.
That's super interesting. Where do you see, you had talked earlier about let's talk about how these things work. The serotonin hypothesis is kind of what came out with the advent of SSRIs to say, hey, these are going to help serotonin be around in your brain more, and serotonin's the happy molecule, and that's how these antidepressants work. That's never been proven. It's called into question, but again, I feel like a urologist trying to understand this. Of I have no skin in the game, and I'm fascinated, but my neurobiology might be blunted. But what it seems to do is it seems to blunt the high highs and the low lows of emotional response. Is that near it?
Go to the top of the class. You're better than most psychiatrists on this topic. I mean, the story kind of goes, in the 60s, there was a hypothesis that depression is caused by low serotonin or norepinephrine. And 6 decades of research has been dedicated to that topic. And basically it's found nothing. We did a review a few years ago. We looked at healthy volunteers versus depressed people, and there was no difference in serotonin in any way you measured it. And now most academic institutions say that this was a hypothesis that didn't pan out, but it's gone wild in the public because drug companies jumped on it. They made ads in America, showing little unhappy blobs with low serotonin in their brains. You give them Zoloft and suddenly they're playing team sports and having great lives. And so it's been stuck into GPs' brains and the public's brains. We know 90% of the public believes this. And so it really is a marketing line. Of course, we cannot boil down a complex state like depression to a single chemical. It sounds incredibly appealing, but it's not as simple as diabetes.
It was very sexy.
Very appealing. And you can just fix it by adding in drugs. So what do the drugs do? If they're not fixing a chemical imbalance like low serotonin, what are they doing? And you said it exactly. In surveys, 3/4 of people on antidepressants say they feel emotionally numbed. That means their experience of very positive and very negative emotions has been squished into the middle. And if you're very panicked, depressed, or anxious, having the volume turned from a 10 to a 3 can be a great relief. But we can't kid people, can't target anxious and negative thoughts. We do the whole thing. We're blunting all emotions, including enthusiasm, love, interest. And so one of the main reasons people come to me to come off their drugs is they say, I used to enjoy music, sport. Now I feel meh. I don't know what I think about my partner. I don't know if one of the saddest things I've heard from a mother is, I don't know whether I bonded with my children properly because I was numbed their entire childhood. So, that's, it's hard to hear. So I think that and you can see, I think it's very misleading when you say to somebody, this drug will fix an underlying chemical imbalance. It's very compelling. It sounds very safe as well. If someone said to me, I've got low thyroid hormone, do you want to take thyroid hormones? I'd say, yes, that sounds sensible. And it's the same kind of story. But if you're actually giving them a drug that numbs their emotions, and that numbing is connected to the numbing sexually. Those are correlated in studies. In fact, if you chew up antidepressants and swish them around your mouth, it will numb your mouth a bit. So there's definitely a kind of mild anesthetic property of the whole thing. And so now you've sort of misled somebody into believing they're taking a drug that's as healthy for them as insulin for diabetes. But actually what it's doing is, it's kind of creating a chemical imbalance because you have a normal serotonin, now you have it very high, and this affects, your hematological system, your sexual system, your brain. It has all sorts of consequences. So I think people are not they're not giving informed consent to take these drugs because they're given this kind of just so story that misleadingly makes the drugs appear safer and more targeted than they really are. And so I think it's not just, a whoopsie, but it's really, really a real deficit of information for people.
Yeah, I say that over and over again. I think we have a failure of informed consent when we prescribe these medications. And I think one argument is, can you truly give an informed consent if you're coming in so sad, so depressed? If the doctors are trying to get you out of an acute emotional event, right?
That's not who is turning up. I'll just say, just to jump on that, because
help us.
There's 56 million people on these drugs. Most of them are not coming in acutely suicidal. We know that most people prescribed antidepressants have mild to moderate symptoms. They're people coming in everyday circumstances after heartbreak, grief, breakups, demoralization. So, there's a little bit of a kind of the advertising, desperate people on the edge. Most of the time it's just general unhappiness.
Unhappiness.
Not pleasant. And you can give informed consent in that situation. So I wouldn't jump at people.
Thank you for clarifying that. To me, I'm like, an informed consent is, we don't know how these things work. They tend to help short term by blunting negative emotions.
Yeah.
After a certain amount of time, 6 months, a year, it actually becomes difficult to get off these things. Do you think there's a window we can tell people where watch it if you want to take this longer than X, because that's when it gets tricky?
Yeah. There's no line in the sand. It's all happening slowly. We know that it's easier in the first 6 months. It becomes much harder after a couple of years. It's already significant between 6 months and 2 years. So I think the first thing is to follow guidelines, get people off within 6 to 12 months. That's a lot better than keeping them on for years. And I'll just say on one point you made, you said these drugs work for a bit in the short term. It's very hard to show that. In studies after studies, the difference between an antidepressant and placebo is 2 points on a 52-point depression scale. And most doctors say you need to see a 7-point difference for a mild improvement in someone's mood. So these drugs are statistically significantly better than placebo. That's true. But in terms of clinical importance, imagine like a weight loss drug that's better than water, but it only makes you lose 1 ounce of weight. It's not clinically important. So people argue the drugs are statistically significantly better than placebo, but the degree is so small as to not matter. So there's a huge debate, are antidepressants effective? I think people say that they feel better, probably because of that numbing. Then there's tolerance effects in the long term, so they wear off. There's all these side effects that I've mentioned some of, and that it's very hard to come off in the long term. So I think that is closer to informed consent than what most people are receiving at the moment.
Absolutely. What resources do you have for people who their doctors don't know how to get them off? They're curious about it. They're afraid of the withdrawal side effects. What resources are established now to help people with protocols?
Right. So
support groups.
Yes, there's a few things. So one, I wrote sort of now the textbook in the field about how to come off the drugs, held it up, the Mortality Prescribing guidelines. Sometimes patients buy that book for their doctors, which I find is a bit tragic. It should be the other way around. Doctors should be buying textbooks. It's because doctors have sort of been taught for so many years these drugs are very easy to come off, and patients plead with them, please go a bit slower. I think doctors are a bit intimidated by this thick book, but you can sort of open it up and it goes to Zoloft and it goes to Effexor in a couple of pages.
Nice.
I have helped to set up a clinic in America called Outro Health because I got so many emails from Americans where I've helped to train nurse practitioners who help people to come off in this kind of slow, gradual way that I describe in the book, that at a rate people can tolerate, that gives you wraparound care. There's also free resources. Actually, Outro Health has a good library that's free for people to read about. The Royal College of Psychiatrists in the UK has a free guide about how to come off antidepressants that I helped to put together that's free for people to read. There are lots of social media sites now, Facebook groups. If you type in the name of your drug and coming off it, you'll probably find a couple of different sites with thousands of people on them. So there are increasing numbers of resources. One place you can't look is in the American Psychiatric Association guides for depression, where it just says come off in a few weeks and you'll have no troubles. So, you do have to go outside a little bit, established institutions at the moment. Maybe that'll change over time.
Where do you see, from where you started on this journey,
Yeah.
where do you see this going right now? Do you see this reckoning happening? Do you see this becoming more mainstream? What are you seeing with your finger on the pulse of this?
I guess my answer to that is I'm in the UK, which I feel is 5 years in front of America on this topic. And what's happened in the last 5 years is there's been 1,000 newspaper articles about this topic. There's been a BBC documentary, a bit like, I don't know, a major channel in America. There's been a government inquiry into the issue. There's been changes to guidelines. There's been directives put out to doctors, please reduce inappropriate prescribing of antidepressants. There's been, opinion articles. There's politicians involved. Has it changed culture in a big way? No, but it's on the edge of that. There's people interested, decision makers, and America is 5 years behind that. You mentioned a couple of newspaper articles, the Wall Street Journal, NPR, even the New York Times have talked about these issues. In the last couple of months, in big psychiatric magazines, they've had kind of argument, counter-argument articles. People say this is a problem, but we don't think it is a problem. The fact that they've got to even argue against it in a public forum means it's becoming more prominent. And I think the real kind of pusher is there is now hundreds of thousands of people on Twitter, Reddit, Facebook complaining about this issue, just regular patients. And at some point, when there's millions of people talking about this issue, it's very hard to ignore. So I think this is this sort of slow tipping point of greater institutional recognition, greater awareness by the public, media awareness about it, and that will slowly, come to be more mainstream. There's a little bit of a kind of complication in America that, RFK Jr. has talked a lot about this topic. Now, as it happens, I don't agree with RFK Jr. about a lot, but I do agree with him on this topic. He's talked about these drugs can be very hard to stop. We haven't looked at long-term effects in children. We should look at it. I agree completely. But because he's sort of seen as a bit of a poison chalice, the mainstream media thinks that everything he says must be wrong because he's with Trump.
It's lost.
It does a bit. It's an unfortunate messenger. So that's a complication in the kind of culture wars in America.
I think the change. To me, I've been paying attention to this topic for a couple of years. I've had this podcast for 7 years, and I'd say even 2 to 3 years ago, I was like, I can't talk about this yet on the podcast. Right. People aren't ready. They're too protective of this class of medications. They're too protective of first do no harm with people. And now that, I saw your book come out and I'm like, great, I actually have an expert now and I'm comfortable bringing this on the podcast.
Right.
I just feel like the time is more right now. There's a big reckoning. And I think the power of social media for people's experiences to be heard makes it more real. But I have to think I'm so incredibly passionate about this topic. It's absolutely insane that these drugs do harm and how they're kind of marketed as they only help. There's so many hot topic issues about this that are just so infuriating to me. But if I became the person who kind of became obsessed with this and talked about it, I know I would be dismissed. People would be like, yeah, but she doesn't like it. There's still a big dismissal for the people who are speaking out against the status quo on this.
Yes. So that's true. And of course, I've been sort of attacked, they try to shoot the messenger. It reminds me a lot of the response to climate change. First of all, people, fossil fuel companies said, or smoking and, tobacco companies and smoking, they said, these are cranks saying that smoking causes cancer or that, CO2 causes climate change, dismissal. Then there was minimization. There are other things that cause cancer. It's asbestos, it's stress. It's
let's distract you. Let's give you a different topic to think about.
Let's not get obsessed with one thing. And they put out all these articles, asbestos, stress, blah, 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 or climate change. Yes, it's happening, but, let's not destroy the entire economy for it. And sort of as there's more and more evidence, they had to concede more and more. In America, they haven't considered very much these days, but in the rest of the functioning world, they have considered more about climate change. And I see the same sort of thing happening. Denial, minimization, arguing. They're sort of getting to that stage in America where they've gone from denial to minimization and now to sort of this argument. And it's, in the UK, they've gone to, I guess, constructive action. How can we solve this problem? they've kind of accepted it. And so, yes, there are people in the UK who say, they say, they're kind of insinuating, maybe I'm a Scientologist, I'm an anti-psychiatrist. I'm a pretty weird anti-psychiatrist. I've taken the drugs, studied for years, done my degrees, prescribed to patients.
Got a PhD.
Got a PhD.
Got yourself off the drugs.
Exactly.
I mean, if not you, who really is my thought of like, you're the
I gotta
perfect
say,
person.
I mean, look, there's more and more people around. It's sort of not just me. There's lots of researchers, doctors, patient advocates, politicians, because truth be told, because 1 in 6 people are on these drugs, everybody knows someone that's had trouble. So every time a journalist contacts me or a politician, I know that they've got a sister or a brother or a wife with the troubles. And I'll give you some salacious stories. I've had senior management from large drug companies contact me to help me get their daughter off Zoloft. I've had psychiatrists come to me and say, I can't come off my own antidepressant. Politicians, journal editors, you name it, because everyone is on these drugs.
Yeah,
and I think that
big.
makes it inevitable that this will come out more.
Yeah. It's fascinating work. It's groundbreaking work. I think it's very validating for people to hear this. I had a patient stop her SSRI pretty quickly, like cut it in half. And she was like, all my menopause symptoms are back. It was like hot flashes, not sleeping, moodiness, blah, blah, blah. And I'm like, you just cut your SSRI in half overnight. Like, get back on that. Those symptoms, we got to do this. You got to do this differently if you're going to do it.
Yes. So maybe I'll just jump on that. That's a big issue. People stop their drugs. They feel terrible. And they think that must mean they need the drugs. It's like the alcohol or smoking example. But there's a word called rebound, which I think can be a bit helpful in this case, which is things that you do have, but withdrawal makes it much worse. So, you do have hot flashes because you're going through menopause, but coming off the drug upsets your system so much it's 5-fold worse. And it's not because you're off the drug, it's because you've come off too quickly. And the trick is, go back on, you come off more slowly, your system is not so upset by the process. You don't get that surge in symptoms. And so that's kind of, if I had to summarize all my work about coming off the drugs, if you do it slowly, down to these very low doses, it can be so gradual and gentle, it doesn't upset your system. I give an analogy like going up a mountain. If you do it very quickly, you get altitude sickness. But if you do it slowly, you don't get altitude sickness. It's the same, you go on the same heights, but it's how you do it. And the same with coming off these drugs.
I love it. Thank you so much for spending time with us and educating us. I know you gave a lot of people a lot of things to think about. And at the end of the day, I'm a physician. I think doctors want to do best by their patients. They want to do right. I think they were given a tool and they weren't told about the long-term issues with the tool. And I think you're part of righting that wrong. So thank you so much for being here.
Thanks for paying attention to this issue. I really appreciate it.
Thank you.
Okay. Bye, Kelly.